chủ đề tiếp theo đó là can thiệp nội mạch để lấy huyết khối những cái cầu nối thận nhân tạo, và chúng tôi làm thế nào. Thì qua trình bày này sẽ được bác sĩ Kerati Hongsakul đến từ Thái Lan. Bác sĩ Hongsakul đã đến từ bệnh viện Hoàng tử Songkla và có rất nhiều những cái báo cáo cũng như là nghiên cứu của trong cái lĩnh vực mà cầu nối thận nhân tạo nào.
First of all, I would like to thank you, ESIR, for the invitations to join the wonderful conference. So for my topics today, I would like to talk about the endovascular declotting of hemodialysis access, how I do it. It is my disclosure. I would like to introduce a bit of my centers. My center is spin off Songkla University, located in the southern part of Thailand. We are the university hospital and the biggest hospital in the southern part of Thailand. And we have a lot of cases of the dialysis. And we are the dialysis centers. Okay, let's move to the contents. For the thrombos of the vascular access, include the AVG and the AVF. The SAWA treatment include the surgical thrombectomy, that is the standard method. However, the endovascular techniques also now is the other standard options to treat these conditions, including the thromboaspirations, mechanical thrombectomy, pharmacological thrombolysis, or combinations. So I would like to focus on the mechanical thrombectomy and the pharmacological thrombolysis. And the concept of treatment using the endovascular, the first one is to remove the thrombus. You should clear the thrombus from the access first, and then treat the underlying stenosis by using the balloon, angioplasty, and all evaluate for the need or no need for the standings at the underlying stenosis. However, the contraindications to perform this procedure, including the contraindication of the thrombolytic duct, and the next is the effects of the thrombos, AVG or the AVF, because maybe it's a high risk of the septic embolisms, and also the infect clot usually have the inside the biofilm from the bacteria, and it's quite hard to resist by the thrombolytic duct. Another is the severe contrast reaction. However, you can use the other contrast, it's like the CO2 instead of the iodinated contrast media. And usually in my center, I use the multi-site hole infusion catheter, 4 or 5 frames embedded into the clot, and then you use the GPA mixed with the sterile waters and infused via the infusion catheters, and you can see the jet flow from the side hole of the catheter, and the jet hole can make the mechanical effects and also chemical effects to macellate and to lysate the clot inside the access. And you can insert both of teeth into the arterial and the venous limb of the grafts, and also you use the infusion catheter placing along the graft is the kiss cord techniques, and use the pulse spray techniques for the lysis of the clot. This is the example case. This patient has the thrombus of the left brachioaxillary lead graft, and it is the vascular teeth that insert for the proximal and distal, and then use the catheter infusions for pulse spray thrombolysis. you can see there's some residual clot, some clot into the grafts, and also the underlying severe cirrhosis of the grafts and the venous anastomosis. And this is after the procedures, after lysis and balloon angioplasty. You can see it's a good result of the physiograms. Another case is a thrombose of the left radiocephalic AVF. From the ultrasound, you can see that the clot inside the AVF. We puncture in the proximal pattern of the cephalic vein and insert the teeth. Also, we perform the angiogram from the vacuum artery to check the axis. You can see it's the line of the cephalic vein, but now it's occlusion. So, but now it's has a thrombose inside. And we insert the infusion catheters and perform the thrombolysis. And after thrombolysis, you can see it's quite open up of the cephalic vein and still residual thrombus and underlying stenosis at the AV anastomosis. After that, we perform the balloon angioplasty to macerate the clot and treat the underlying stenosis. And this final results with the good and pattern of the axis. Another case is the thrombose of the left brachiocephalic fluid graft. And from the picture, the clot involved into the graft, and also you can see clot extend into the cephalic vein and cephalic arch. In this case, from the other side, you can see that the clot inside the lumen of the vessel. And in this case, due to the clot is very long, so, and the extensive of the clot, we use the mechanical thrombectomy. In this case, we use angiojet for the remove the clot like this. It's a bit forward. The clot will be resist and removed from the angiojet catheter. And this angiograms after lysis the clot, after remove the clot by the mechanical thrombectomy is quite good. And for the cephalic veins, it also is patent. However, we found that after these angiograms, we found the axis still is a pulsatile, is no teal. So we find the other point that may be still stenosis. So we found in this point at near the cephalic arch at the stenosis and some thrombus embed here. So in this case, we decided to put the stent, and then after push the stent, the axis is slightly full, and also we can palpate the teals. That means that it's the success of the procedure. Also, we check with the ultrasounds. It's a pattern, no residual clot in the AVGs, and also this Doppler calendar sound also is a good. And for the procedure, post-procedural evaluation after the angiogram should be, the final angiogram should be pattern of the AVG and with the greater than 30% of the residual stenosis, and also by the clinical should be palpate the tubes. And the patient usually normal first hemolysis after the procedure. And this is our data that compare between the surgical thrombectomy and thrombolysis. The vascular thrombolysis in the thrombose hemolysis graph for the procedural success is not significant between two procedures, and also the mean patency time also is not significant difference about the 6 months. And also for the primary patency in the 6 months and 12 months also is quite the same. It's not significant difference. However, from the meta-analysis and review that show the outcome of the AVG treatment with the endovascular compared with the surgical treatment at the 1 year's primary non-patency usually found most in the endovascular treatment. So for the meta-analysis, conclude that is the 1 year primary pregnancy is quite better than in the surgical thrombectomy group. Again, it's the same in the 2 year primary non-pregnancy. Also, it is quite better in the non-surgical thrombectomy group than endovascular group. And the result of the thrombolysis of the AVF, it is also our results, our center. The clinical success rate is around 85%. Technical success rate is around 85%, and the clinical success rate around 100%. And the patency rate, the primary patency rate is 6 months is around 70%, and also the 1 year around 60%. However, the many data show that the result of the surgical thrombectomy compare for the surgical thrombectomy and the endovascular treatment in the thrombus of the AV fistula. From our data that show the primary patency at 1 year is quite better than in the group of surgical thrombectomy compared with the endovascular group. And that for the complication, the major complication for the thrombolysis including maybe is a non-target embolizations, it's like a symptomatic embolization into the arterial size, and the hematoma or the bleeding side, the effects may be from the thrombolytic ducts, the vascular perforations, death, and symptomatic pulmonary embolism. However, the ratio or the evidence or incident is quite, it's not high, it's just a lower. For the pulmonary embolisms, usually after we perform the procedure and thrombolysis, usually the clot maybe is like the microemboli to lock into the pulmonary embolism, and the patient maybe is subclinical condition, is no clinical of the PE on the subclinical PE, because that I show the clot is just the emboli that can be the internal autolysis. However, there are one case reports about the patient developed cardiac arrest after perform the thrombectomy in the AVF, because the large clot may be locked into the main pulmonary artery that can found. For the conclusion, pharmacomechanical thrombolysis is the minimal invasive techniques and the effective, durable, and the safe procedures. And it can be an alternative treatment for the thrombus dialysis vascular access, including the AVG or the AVFs. And also for the advanced techniques, like the mechanical thrombectomy and the equipments, usually can be the enhanced outcome of the procedures. Thank you very much.